Welcome back. We're going to get started with a panel discussion, which I've been very excited about for some time now. We have some unbelievably distinguished panelists that are with us today. And if you would, guys, and Ben, and then there's Ben, right? Right. So if you all indulge me, I'd like to talk about each one of them. Ben, there's nothing, I have nothing on you here, so. Dr. Chismar, we'll start with you. So Dr. Chismar serves as the State EMS Medical Director at MIMS. He's board certified emergency physician and EMS physician. Dr. Chismar graduated from the University of Maryland Medical School, completed a residency training in emergency medicine at the University of Maryland Medical Center and the R. Adams Cowley Shock Trauma Center. Dr. Chismar has maintained an active, definitely active, clinical practice in emergency medicine and EMS for over a decade in the Baltimore area, and we're very fortunate to have him as our state EMS medical director. Thank you. Welcome. Dr. Garfinkel, hard to follow that, but here we go. Dr. Garfinkel started his EMS career as a volunteer EMT and paramedic in Pennsylvania. His residency and fellowship training were at Johns Hopkins, and he's board certified in emergency medicine and EMS. Currently, he serves as the assistant medical director of the Howard County Fire Department Rescue Services and the assistant medical director for Johns Hopkins Lifeline Critical Care Transport Program. Eric, thank you. Welcome. Holy cow, look at this one. This one's really long. All right, get ready, buckle up. Here we go. Dr. Launer. Dr. Launer's interest in emergency medicine began at an early age. He completed EMT school in 1994 and secured his first pair of trauma shares shortly thereafter. Until 2001, Ben worked for the Alachua County Fire and Rescue as a lead paramedic and firefighter. Fortunately for that population of North Central Florida, he was never detailed to the fire suppression unit and remained, quote, stuck on the box for his duration of time there.
Jokes are free, man.
Graduated from Nova Southeastern University College of Osteopathic Medicine in 2005. Completed his emergency medicine residency training program at the University of Maryland. He serves as a chief resident, faculty development fellow, completed an EMS fellowship, and is now the medical director for Baltimore City Fire and Maryland Express Care. He was the recipient of the National Junior Faculty Teaching Award for the American College of Emergency Physicians. And in 2018, GEMS recognized Dr. Launer with the John P. Myra Street Medicine Society Award for contributions to pre-hospital medicine and education. Dr. Launer, welcome.
I'm a friend of Zapcasm too.
Dr. Matt Sasser, current medical director for MedStar Transport and has been with the program since 2018 in the role of assistant medical director and then associate medical director. He is currently an emergency medicine physician at Union Memorial, former medical director of the Reading EMS in Reading, Pennsylvania, volunteered at Bladensburg Volunteer Fire Department in Prince George County, Maryland, and Forest Hills Volunteer Ambulance Corps in Queens, New York. He was born in Baltimore, Maryland, studied undergrad at University of Maryland College Park, medical school at St. George's University School of Medicine, residency at Penn State Hershey Medical Center, where he was chief resident, and then returned here to Maryland to practice and has been here since that time. Welcome.
You are my hero.
Finally, Dr. Dylan Morris is an emergency and EMS physician with particular interest in air medical transport and critical care, EMS operations, healthcare systems integration. He completed medical school at the University of Rochester, residency at Oregon Health Sciences University, and EMS fellowship at the University of Pittsburgh Medical Center. Finally obtained his MBA in healthcare through the Katz School of Business. He currently works as an attending at UPMC Mercy in downtown Pittsburgh, provides online medical direction to numerous EMS agencies and ground-based consultation to several commercial airlines for in-flight emergencies through Stat Medevac. However, most of his time is spent as an assistant medical director for Stat Medevac. All right, welcome everybody. One other exciting thing to talk about that's coming soon. So we're in the process of developing and have developed a Center for Out-of-Hospital and Resuscitative Medicine. That just gives us another reason to do this kind of stuff all the time. In the spirit of academics, it's going to be a three-pillar center with clinical innovation and clinical excellence, education and research, and just really a great opportunity to pool resources for all the talent that we see here and be that center of excellence for the region and for the nation in critical care transport and resuscitative medicine. So look out for this. This is coming soon. Classes, research, a great way to collaborate. So we're very excited about it and hope you guys are as well. All right, shall we kick it off?
Just a housekeeping thing. You guys have all these slides in front of you, so you don't have to keep turning around. Because I don't want you to get a crick in your neck. All right, there we go.
All right, case number 1. Here we go. So 36-year-old male, motorcycle collision into a guardrail. Luckily did have a helmet on. When EMS found him, they found him to have a compromised airway. He was hypoxic and receiving back valve mask ventilation, was hypotensive, had a GCS of 3 with EMS, and received a right needle thoracostomy. He was brought to the emergency department where he was promptly intubated, and the trauma team was there as well. He was diagnosed with the following: bilateral pulmonary contusions, he had bilateral pneumothoraces, status post chest tubes, and a right-sided rib fracture. He took the brunt of the injuries all on the right side and had a large soft tissue defect to the right femoral artery, which is now status post repair, had a ligation of the femoral vein, but despite that is having ongoing bleeding without the ability to surgically control that wound. In terms of the neurologic status, again, he had a GCS of 3 when he came in. He was intubated for airway protection. He has a small frontal lobe contusion and a small subarachnoid with no evidence of shift. Current set of vital signs we have of 88/52. His heart rate is 158. His respiratory rate is 24, satting 91% on the ventilator. Settings as you see them there. He's on PRVC with a tidal volume of about 500 cc's. Respiratory rate is 24. His PEEP is 15 already, satting 100%, and peak pressures are 38. He's on multiple vasoactive infusions to maintain his blood pressure. Norepinephrine at 0.7, vasopressin at 0.03, and phenylephrine at 1.5. He's already received 20 units of RBCs, 12 units of FFP, 2 units of platelets, and his right groin is packed with hemostatic gauze, yet still bleeding. You have about 35 minutes by ground. The helicopter is red for weather to get to the transport, to do your transport to get to the receiving facility. So I would say probably we call this Monday, right, in our world. A fairly common case that we see, but multiple nuances to discuss with respect to clinical care. So I guess, you know, the first question is, and I'll throw this to Dr. Garfinkel as the junior member of the panel. Welcome. We start there. So, you know, you get this call from one of our crews. They want to do a pre-consult. We have this information. What kind of things are you thinking about? What is sort of your game plan that you want to run with the team as we're sort of gathering resources and about to sort of run out the door to get to the patient?
Great question. I think, you know, the first thing I'm thinking about is how can we maintain hemorrhage control during transport? And do we have enough blood products to get this patient to where they need to go? Over what time period have they gotten? Eric, use the mic. Turn off. They're all on, I think. So over what time period did they receive all these units of blood and blood products? That's what I want to know, because if it's over a short time period, then we're in trouble. That's helpful, Eric. I appreciate that advice. You're in trouble. You're welcome, Sam. Good luck. This is how. Good luck.
Thank God it's Sam. You're still in trouble. You know, the weather clears as we sort of leave, and now the helicopter is going to be a go for transport. You know, we pass the call now to you, Dylan. You know, the crew wants to pre-plan again. What kind of things are you thinking about?
So we don't allow our crews to pre-plan. We would get them to bedside and ask them to call us from bedside.
Great.
You know, and we're gonna see what resources we have available. Our helicopters carry 2 units of blood under most circumstances. Though with ongoing trials, we may have 2 units of whole blood. We're gonna ask the sending facility for as much blood as they can possibly give us. And we're gonna have a frank discussion. You know, this is now probably a 9-minute air transport. That's a lot more feasible than a 35-minute ground transport.
Awesome. Anybody really see the value of sort of the pre-planning, right? Because we hear about this. Can I call and discuss this? Is there value to sort of getting resources together, or is it better just to get to the bedside and figure out exactly what we're dealing with?
I think it depends on the mission, you know, if that question was directed at me, you know, a stable ECMO patient that's gonna have a lot of specialty needs, absolutely. A case like this where it sounds like they don't have surgical control of hemorrhage and you've got a time-dependent process, and they're literally pouring through blood products. I don't know that we're going to do a lot in the pre-plan that isn't already being done at the sending facility, and we're being asked to transport this patient for speed, rather than a clear pre-planned addressable need other than access to blood products.
Awesome.
I would say one question is what's been tried so far as hemorrhage control. It says surgical ligation, but is there a junctional tourniquet device that maybe we have available that is not available at the outside facility?
Yeah, agreed. So, you know, we get into this concept of hemorrhage control, and sort of balance with hemorrhage control is resuscitation. So Dr. Sasser, I guess sort of what's your approach to balancing sort of how do we approach hemorrhage control? How do we balance resuscitation? Sort of where are we in the resuscitation of this patient and what kind of adjuncts can we bring to the patient's side?
So I would say that at least for MedStar transport, what we would do is we would, number one, focus on hemorrhage control. Does the sending facility have a femstop, something other, or some other way to cause mechanical hemostasis for this patient? I think that's going to be the primary answer. We don't carry blood products, so we would be obtaining blood products from the sending facility. Again, like he mentioned, we would be getting as much as we could with about a 10-minute flight time. I think that would be minimal with our ground critical care. Again, we would also be asking for the most blood products that we could have available. Obviously, the patient's still tachycardic, hypotensive. They're under resuscitated at this point. But if this is the best that the sending facility can do, then it's a risk versus benefit discussion with the sending facility. Is it better to just take the patient, take the blood, load and go with whatever compression we can get for hemostasis versus staying and playing, which I don't think is the best answer for this patient.
Yeah. Ben.
So where's the Maryland Air Force so we can airlift the surgical suite to the scene of the emergency? But so I would say that there's a couple things and with this, because this is like the specialty, right? I mean, we love, and thank you for the difficult, impossible questions, right? We don't have the ability to get surgical control, but I would focus on some of the basics. So it's always good to take that deep breath because in Maryland, we do have the availability of surgeons. So you can consider, for example, Reboa, if you can bring somebody to the scene. I think the pre-planning of blood is a major issue for us because we don't carry blood products. We have to steal them and beg from Hopkins or other places to get the blood. So when you have somebody with massive hemorrhage, and this is clearly a massive transfusion patient, you'd have to use one of Stat's like 28 aircraft to bring additional blood products to the scene. So finally, what I would say is it may be 24. I don't mean to exaggerate, but what I would say the last thing about this, and this is a great issue with trauma resuscitation, is that you have to optimize what you can. So we definitely have a couple of things to do here. And without belaboring the point, I would say you can think of such things like TXA and calcium. And then you could also back off a little bit on the positive pressure, because as we know, in these hemodynamically tenuous patients, 524, there's a big issue with expansion. So, one of the things I tell my crews is really take it a step at a time or a system at a time and see where you can maybe optimize or modify what is clearly an impossible situation.
Great. You mentioned some adjuncts, right? I guess we could debate to what degree they're adjuncts, but things like TXA, where does calcium fit in? The crews at the bedside are getting information on a very complicated patient. There's multiple things they need to do, not the least of which is expedite, right? How do we help them prioritize both information they're receiving, which may not be in a very ordered fashion, and things we want them to do and things they're thinking about? What kind of tips do we give them? Anybody wants to take a stab at it? All right, Lana, you're up.
Well, where's MedStar? So what I think, that's right. They're down for weather. But the situation like this, and I think this is a great point because we talked about this a little bit in one of the lectures about, human factors. And I think you really need to train for situations like this because the reality is there's really no way to prepare. And we get stuck in this loop of you need to stabilize the patient prior to transport. clearly this is a patient that is in need of definitive care. So we have to figure out what resources we can give. I do not have all the answers for a patient like this, but I think training your crew members and training to think as a clinician, meaning you take it by system and you look at everything that you can or cannot optimize. So a patient like this, where you have multiple things failing all at once, it's always appropriate. Just looking at this case, for example, you mentioned the junctional tourniquet, I would say a pelvic binder. So when you're going through these things like musculoskeletal trauma, just check off the easy low-hanging fruit boxes so you can continue to work the problem.
Right. Other thoughts? Dylan, were you gonna mention something before?
No, I mean, I assume we're picking up the patient in the operating room, and there's going to be a very anxious anesthesiologist who's going to be trying to push us out the door in our experience. And so trying to balance, you know, how much information the crew needs to process, how much ability they are going to be able to make any forward progress with not, you know, literally being pushed out the door, which may mean one of us getting on the phone, a medical director getting on the phone and essentially running interference with the anesthesiologist for a few minutes to buy our crew a couple of minutes to make forward progress. You know, they probably know what they need to do. Are they being limited in their ability to do it by a very stressed surgical team is another part of the equation.
Yeah. You know, Ben, you mentioned something interesting about, you know, bringing the surgical team to the patient. How feasible is that? You know, whether university, Hopkins, MedStar, UPMC system, right, being out in the community, how feasible is it, you know, Dr. Chismar, to, you know, being at a community shop and, you know, getting somebody from University of Maryland, the mothership, so to speak, to fly them in and get the team to the patient rather than getting the patient out the door?
Yeah, I mean, I think it's very interesting. I think there are opportunities certainly for growth. I mean, I think as Dr. Lawner said, we have an ability within healthcare systems through cross-credentialing to bring surgical teams. You know, and this is something that I think we're continuing to look at, you know, how can we bring that, and I'm really not aware of many cases where it's done successfully. We've talked about it a lot, but it's something we certainly could make a lot more progress on.
Yeah, I could say if this was a 36-hour-old that was driving that motorcycle, we could get our NICU team there awfully quick. But we are in discussions with our other teams. We don't have anything in effect right now in terms of getting our teams out to the patients.
Dylan, what about within the UPMC system? Have you guys been able to figure this out?
We have, but the lift is rarely worth the squeeze. You know, especially you're talking about a transport of 10 minutes. Trying to marshal a team and bring them there is almost certainly futile compared to bringing that for a transport of this duration. I think that is just not.
Yeah.
So I would add that I think we've made so much progress as a critical care transport industry. And I would encourage us to think about how we can bring those resources within the team. The fact that you can bring blood and paralytics and all these resources and medicines means that you can stabilize overwhelmingly the majority of patients. And the fact is transport is a treatment, because even if you look at trauma, getting a surgeon free is going to basically take a large amount of not only lifting, but a large amount of resources. So I think when you ask those types of questions, you have to say, you know, what is the specific intervention that they may require? And I think there are very few of those interventions that cannot be done by maximizing your stabilization, medical optimization, and trying to expedite transport.
So let's hammer that down for a second. The crews want to know, like, hey, you sent me with this cooler of blood, or I just received this cooler of blood. This is what they got. The patient is still actively hemorrhaging. I don't have a junctional tourniquet. I don't have ZAF to put in Reboa, right? So I have to sort of continue to give them products along the way. What is your sort of guidance for what to transfuse and to what point? Do you want to get them off pressors? Like, should we transfuse them to get them off the pressors? Should we wean down norepinephrine? Should we, you know, give 3 more units of reds before we start giving some FFP? Like, what sort of tailored guidance do we give them rather than, give more blood, give more products? Anybody want to take a stab at that one? Go ahead, Eric.
Well, one of the things that I'd say is that we're really far behind on calcium. here, and calcium should be a staple in managing our patients that are massively hemorrhaging. Don't know how much calcium they've got. And depending on how long the patient's been hemorrhaging, some blood work might be helpful. Although I don't know if the blood work is just going to be the blood that we've transfused. So that might not be helpful either. A TEG could be helpful. And then 1-to-1 transfusion would be ideal if we can pull it off. Looks like the ratio here is pretty far off of what would be ideal.
Other thoughts? Where do we have them start? So what are they transfusing next? And sort of what ratio?
I think we give a couple of amp calcium while we're getting FFP on board, frankly, it's probably where we do that.
Agree.
And then start adding a calcium every second that we gave. We have enough available.
Other thoughts? I mean, calcium is one of those things that's sort of been a moving target, right? We used to give it after, I don't know, 4 or 6 units. And now some people are giving it with their first unit because not only are they bleeding, but they're losing calcium. And, we know calcium is an important cofactor. Some people are giving it after 2 units. So it's a little bit of a moving target. Any other thoughts out there, Dr. Chismar? Any thoughts about like sort of where calcium comes into play and how you as a, state medical director, we're going to be having blood pretty soon, right?
Yeah.
So how do we prioritize when we're giving calcium, we're giving whole blood? What are we doing?
No, so it's a great plug for whole blood. And we're looking forward to that. I know Dr. Flocare has invested a lot of energy into that. So we're looking forward to seeing that on the aircraft and the 911 scene response very soon. But I think to answer your question, Asa, I think we certainly know the effect of citrate and the need to give calcium, at least as you said, every 2 to 3 units. And we're clearly behind here. We're definitely not in a 1-to-1 ratio. I would also want to know, this person's been on the operating room table, presumably for some period of time. Are they hypothermic? Hopefully not. But that would be something we want to address as well. I'd also want to know, and I don't see it here, what our access looks like, just, before we take off and transport.
Yeah. So, as per usual, you have, 2 peripheral.
We don't have bilateral
Cord.
courses. Yeah.
We don't have bilateral cortis subclavians, right? We have
Right.
2 peripheral points of access, and there's an IO as well. And that's right. And typical, right? And that's what we find ourselves with.
So I wonder if we'll actually get consensus with medical directors here. This is my opinion, but I think calcium is one of the most overthought and underutilized medications in the scenario. So as long as you're not using it to replace blood, like clearly we need to resuscitate, we need 1-to-1, we need whole blood, but we know in 2023 that 80% of your massive trauma patients are hypocalcemic. We know it's a positive inotrope. We know it's got citrate effects. I don't understand why we don't give it. In other words, when you have somebody who's dying, what is the harm, right? When you're trying to figure out what is going on, because quite honestly, nobody here has said, let's get an ionized calcium, which we're probably not going to do, right? We're not going to wait for a TEG. Although the R. Adams Cali Shock Trauma Center of Excellence is probably running 5 TEGs immediately. But my point being is we've got to check off the low hanging fruit. And I would argue that calcium, and it's not being cavalier, but we know that calcium has a wide variety of physiologic mechanisms. So I would say, in my opinion, this is something where just give it along with the other resuscitations. And if you want to make Dr. Chismar mad, just give bicarb 2 just because. Because that would be fun. Okay,
Sure.
yeah, just.
Wasn't there a lecture earlier?
So you brought up the hypothermia piece and that triggered something for me, maybe triggered me. Maybe that's what that's the best way to refer it. Is cold blood better than no blood? If I can't warm it, and this patient's been on the operative table for 2.5 hours, right? While they try and get source control or hemorrhage control. Is cold blood better than no blood?
Well, if you don't give them blood, the blood in their body is going to get cold when their
Sure.
heart stops.
Fair enough. That's the question. So am I making the coagulopathy worse by giving them cold blood? We should always have a warmer, right? We know that's the answer. But am I making it worse? Or should I just give nothing, continue to press them and get to control?
No, I think you need to give the blood, and you can warm them in other ways. Like you can do, passive warming. you can cover them up with a blanket, all different types of things, but if they need that oxygen carrying capacity, they need it regardless of temperature.
Prioritization, we talked about TXA. Where does TXA come into play here? How do we prioritize that? How do we help our crews prioritize TXA? We have uncontrolled bleeding, right? We're packing it with hemostatic gauze, not working, clearly. We're giving product, we're giving calcium, presumably. Somebody's probably trying to make some sort of vent change here. So how do we sort of prioritize TXA, and in what dosing are we thinking about it, right? So we have our 1 gram over 10 minutes. We have our 2 grams over 10 minutes. We have our 2 grams as a push. The data is sort of a moving target a little bit. So what kind of instructions are you giving to sort of prioritize this, and what dose are you thinking about in this type of patient? Matt, do you want to jump on that one?
So I'm going to say that number one, I'm going to ask for a lot more access than my 2 peripherals and an IO, maybe a second IO, or maybe real access if they're in the operating room. I would assume at this point, if they have actually received, operative intervention as well as 20 units of packed RBCs, they would have had time to put in something more significant. So I would certainly hope that if they didn't, then we would be able to, in which case I would be really transfusing things in parallel. So, I would have TXA as one of my higher go-tos that I would go to in this patient, in addition to obviously, hopefully warmed blood, if not cold blood. And then again, working on the 1-to-1 ratio, followed by, actually, I would probably put calcium right up along with the TXA.
Other thoughts? Why not? There you go.
Stats checking the lactate, just dumping the 2 grams of TXA.
Yeah, we've definitely gotten the blood gas.
That's right.
No,
The lactate is 6.
it's really high. It's so high. Yeah, I don't know quite what to do with the TXA, frankly. The dosing, we're going to use the crash 2 dosing, where we're going to give a gram over 10 minutes and then leave the rest of it to follow. What role it plays here, I honestly don't know. It's not life-saving. Stamp would say for a patient with blood pressure under 70, there's some benefit to it. This guy certainly qualifies. On the other hand, I think most of it's also going to end up on the floor of my aircraft. And so, I just assume spend my time pushing blood product and not weigh down the crew with another truck. They have to draw, dilute, infuse, tie up a line. Not high on my priority list.
Dr. Shizmar, I mean, TXA is relatively new, right, to the state. What kind of guidance are we giving our EMS clinicians out there about prioritization of TXA? And now when blood eventually makes it to the streets, how are we going to sort of prioritize blood, TXA, hemorrhage control, all those things they need to do?
Sure. So, I mean, I think it falls in and just as was said, I think we prioritize obviously direct hemorrhage control, followed by whole blood, or blood products if it's available. And I think TXA kind of falls in there along with calcium. At some point, we need to get it on board, and we've sort of looked at the STAMP trial data. I know there are some places that are just sort of giving it for isolated tachycardia, but I took very seriously the fact that, under 90 and under 70 is where you really start to see some mortality benefit. I think, again, it falls in, along with calcium, but I think the priorities have got to be direct hemorrhage control, along with getting some blood started. We've given it 150 times in the 911 world. And I can say that we've actually been quite good with and very judicious in giving it. Again, I think this person's still clearly hypotensive, tachycardic. There's no argument that they're still in shock. I don't see the harm there.
Are any of you sort of asking that question of what is the goal of the transport here? Right? This patient is super sick. They've gotten, 20 units of REDS, 12 of FFP. They're on pressors. The pressor doses are escalating. The team is telling you the patient has no neurologic exam. They're not on any sedation. Their heart rate's, 158 and climbing. By the end of the consult, it's 170. The pressure's now 60s. Like, are we talking about what are we trying to affect with this transport? Where does that come into play into our discussion?
I'd be lying to you if I didn't wonder why in the world we've got surgical exposure of the femoral vein and we don't, efforts at direct pressure on the vessel haven't been effective. I mean, ZAP is great with the Roboa, but this is femoral vein. I would like to think that something as simple as manual direct pressure on the site, since we've got it exposed. And that's something, again, that I think our clinicians might appreciate the guidance on as well. I know that's overly simplistic, but just something that's been percolating in my head.
So and this is, you can't even say this with a tongue in cheek, but I think we have redefined this issue of what's too unstable for transport. We quite literally had a case not too long ago where there was a necrotizing fasciitis of the neck with no blood pressure, and the person's on ECMO due to cardiogenic shock, sepsis, and overwhelming inflammatory response. The point being is we can do it, but should we? Now, in this case, you have a 36-year-old male who is responding to resuscitation, and the initial consult stated that there was a small subarachnoid contusion, I believe. And so I think this is just as transport as a treatment. We have a lot of resources, we have a lot of lives, machinery, and everything else at risk. And I think that is something where you get to the point where you have somebody with no vitals or the possibility of dying en route is really important. It is good to consider that. And I think just like with any mission, you always want to say, well, what is the point of the transport? If the point is to offer definitive care therapy, such as better operative exposure or some type of definitive care therapy, then I think that weighs into it. So it is absolutely appropriate to ask that question. I think that can be very difficult for crews to do, especially if they're walking into an operating room. But that's something I know that we deal with not on an infrequent basis when we're tasked with transporting patients with no hope of life, such as the subdural with herniation, right? Sometimes you have to say, is it worth the risk if the expectation of neurologic outcome is zero? In this case, it just did not appear to be based on neurologic injuries.
Other thoughts before we conclude this and move on to the next one?
So I'm not sure how other programs do it, but I mean, this is one of those cases where our medical team would get directly on the line with our medical control. We would have a conversation with the sending physician and really talk about the risks and benefits. What is the outcome here that we're expecting? What is the goal? Are we working toward getting toward definitive care, or are we just prolonging death to get it out of their door? And I think those are fair questions. I think those are reasonable questions. And I think that a lot of times we can come to a very direct answer. And a lot of times it is based on what resuscitation has already been done, what the current vital signs are, and what the prognosis is. But I don't know how often other programs get the medical control on the line so that we're taking our teams out of that conversation, at least initially.
What is, it's a great follow-up. What is the role of the EMS board certified medical director who specializes in critical care transport in this discussion? What is our role? Are we sort of making the suggestion? Are we following the suggestion from the sending facility physician? Are we getting the receiving facility online to hear what they have to say? Where do we sort of come in to this very complicated clinical picture to sort of help guide not only what is the best use of resources and crew allocation, but also what is the best interest of the patient? Very sort of complicated situation. Any thoughts, Dylan?
Yeah, I'm with Dr. Launer on this. I don't read anything in here that says this isn't a patient that we can't save. Admittedly, it's a long haul, but this isn't an 86-year-old with metastatic cancer and a GI bleed through a Minnesota tube that we're not going to be able to control. That's a patient we would absolutely get on the phone with the sending physician and say, I just can't move this patient in a meaningful way, and we need to rethink the transport. This, on the other hand, is not going to be an easy lift by any stretch of the imagination, but it strikes me as a patient that does have a chance. If the accepting facility thinks that there's a potential salvage therapy that isn't available at the sending hospital. But I do think there is absolutely a role for the medical director to be involved in a conversation with a sending or referring physician in a patient that clearly isn't stable and likely doesn't benefit from that transport. And we do that with some frequency. It's admittedly very hard to operationalize this once you already have a crew at bedside. Standing down that transport is not an easy task. And I guess in my system, we have 40 hospitals. It's a lot easier to do it from within system, a UPMC to UPMC transport. We feel a lot better about having a conversation about goals of care than from a referring partner, where it can be much more difficult to have a frank discussion about whether we're gonna use that patient in the system.
So I think this is echoes of COVID here, because we had this conversation regularly when we were bringing everybody that we could not oxygenate or ventilate, to an ECMO center. And the outcomes of COVID and intra-transport arrest were absolutely terrible. And the worst place for a transport crew to be is faced with an impossible mission and no support. So I would agree, I don't want to be the person that says absolutely not, because I have a lot of respect for what goes on the clinical bedside. But one thing that we found, and obviously there's no data necessarily to support this, but when you're an advocate for your crew, you can do things like an intra-transport DNR. Like if you want this patient moved and you feel this is risk benefits, that may be fine, but we are not going to attempt resuscitation. This, for example, came up a lot with the prone patients that we were transporting, and what happens if we go into cardiac arrest. And we went down the rabbit hole of how are we going to turn off, we're going to go to the bedside and switch the patient in flight. And so we just said, no, right? I mean, that's where I think the EMS specialist can advocate for crews based upon their knowledge of a very uncontrolled and unpredictable environment.
All right, awesome. Thank you for that. Let's switch gears a little bit. We're going to go to another case. Going to introduce Sarah, who's one of our PEDS colleagues. Spoiler alert, this is about all patients now.
The best kind.
Best kind.
Oh,
Okay. All right. Okay. So we're gonna put on our EMS hats now. You're an EMS director for a scene team. So the scene team is dispatched to a apartment complex for a 4-year-old male with difficulty breathing. The family says he's out playing all day in the pool. No one is supervising them, comes in, can't breathe. The symptoms start about 5 minutes prior to arrival. Your EMS crew gets there. There's found a 4-year-old with stridor, respiratory distress, and with facial swelling. He's alert and oriented. There's no signs of trauma. His heart rate's 160. Respiratory rate is 44. He is pale and warm. SATs are 96% on room air, and cap refill time is 2 seconds. So how do you want your crew to approach this? What do you think is the best way to approach this child?
Ben, this happens in Baltimore City. What are you telling your city medics?
if we can get the ambulance there, that's one thing. Yeah.
Grab a truck there.
I know. City. So on the EMS medical director hat, I have to say, this is a very difficult scene because we have a huge cultural shift. I mean, I know that I have so much respect for pediatric transport teams and pediatric specialization, but we know now that sometimes there is a role for a healthy pause. So if it is a first responding unit that is ALS, I think we focus on those life threats, and especially if it's Baltimore City or any other EMS jurisdiction with a sudden onset of respiratory distress, we're really thinking about things like perhaps anaphylaxis or an allergic reaction or asthma. And those are things that benefit from, I think, assessment and treatment. So the first thing is, if you're able, certainly take that deep breath to assess the patient, because the first pitfall is when you get caught up, and rightly so, in the stress of a 4-year-old that can't breathe. Sometimes the worst thing to do is we actually have a term for this, when we abscond with the baby and you just start running. And that is something that unfortunately rarely leads to a good outcome.
It said no running allowed.
I know.
And does it change the plan, right? Ben, you're talking about Baltimore City where there's a hospital every 45 feet. Is there a difference when Dr. Shizmar, you're talking about a team in Cecil County where it's a ways? Does that change how you approach this kid or not really?
Yeah, I think, being in the rural parts of the state or the suburban parts of the state, sometimes you're really faced with a risk benefit as far as transport goes. I mean, as Dr. Launer said, when you get in this stressful situation, sometimes you've got to reduce it back to as simple of a thing as you can. And really assessing, airway, breathing, circulation. I know that's trite. We talk about it all the time. But, in this kid particularly who's got respiratory distress, stridor, facial swelling, what I'd kind of expect the initial approach to be is try to get a basic history. Is this, are we dealing with trauma? It says no signs of trauma, but are we dealing with allergic reaction? Are we, what is it that we're dealing with, and how can we get that intervention into play as early as possible? I know that we emphasize, and we've been trying to emphasize more across the board, resuscitate to the greatest ability that we can prior to moving. We have been looking at this closely. I know Pennsylvania looked at this quite a bit, but looking at our cardiac arrest rates really after we start transport. So patients that are not in cardiac arrest when we get there, and we scoop and run, and we find out that a lot of those folks end up in cardiac arrest, whether children or adults. So I think the guidance for the initial 911 scene crew is to focus on the ABCs, try to get as pertinent of a history as possible and initiate those interventions that we know save lives very early on.
So now you are 45 minutes away from the closest pediatric center, and you're about 15 minutes away from the closest hospital in general. Where do you want them transporting to?
Where do you want them transported to?
Yeah.
Yeah, so I mean, I think in this case, I really have concern about how secure the airway is. So honestly, every case is unique, but I would not have any qualms about going locally if we're not able to, provide a stabilizing force for the airway. And again, if we're in a jurisdiction that has the ability to do that, then certainly we're able to resuscitate and transport the extra distance. I think that's reasonable. I'd certainly wonder what we've done so far, what we've initiated, whether we can initiate something that might allow us to go to the more distant place. But an unstable airway is definitely a reason to be going to a local facility if we can't stabilize it.
So you give him some IM epi, you give him some albuterol, give him some fluids, and his face becomes more swollen and more difficulty breathing.
So I'll go down the road of assess his breathing.
He's satting okay. He has diminished breath sounds throughout. No wheezing, just that stridor you hear, just mild stridor.
So he has diminished breath sounds throughout.
Mhm.
And I guess, with regard to the swelling, is it just diffuse? Is it localized
Diffuse.
inside?
Diffuse over his entire face.
Yeah. So, I mean, this is a tough call. I mean, I think we've got to prioritize, again, ventilating through any means possible. So whether that's if the child is willing to or will accept an airway adjunct, and we're able to ventilate, then I think we need to start ventilating.
He's awake and alert, fighting you.
He's fighting you.
Mhm.
Yeah.
He's not gonna accept anything.
So
but
do we have any more clinical history as to what happened?
Parents are poor historians. They just say he was outside and he came in, and that's how he is.
So on our exam, do we find any other pertinent findings just on a quick? Again, we're
Nothing.
told no trauma, but we all know that can be,
Deceiving, right?
Yeah.
Mhm.
And by the pool.
yeah.
The pool. No history of drowning. All right, so your crew decides to take him to a local ER because he is in severe distress. So when they get there, he's tripoding in the ER. They do an X-ray. Is the X-ray on here? I thought you put it on here. Okay, so they do an X-ray. I'll go back. That looks like this. Is it behind you?
You probably can't see that on the slides in front of you.
Oh, did you change it? Go back one. Okay. So that's the X-ray they get. So they find a large right-sided pneumo, they decompress, they put a chest tube in. They repeat the X-ray. They find a left-sided pneumo and they put a chest tube on the left side. So a pediatric center is called and your transport team is sent. All right, what are you thinking now?
Not my problem.
Amen.
Okay, how's this?
Well, no.
The pediatric team is not available,
Yep.
so your team now has to go retrieve this patient.
So Hopkins Peds punted to medevac 10 and I pick up the phone and call you.
What do you want me to do? What Sam's gonna say.
This never happens. I've never heard of a pediatric team being unavailable ever. I mean, I just heard from Bruce Klein that there's no such thing as generalist teams that take these patients. Challenge accepted.
Except
Yeah. Where's Philomena? We got you.
What are you gonna tell your crew?
How's the kid doing now?
Right, your crew gets there. They've been dispatched. They arrive and find the patient tripoding, heart rate of 170, respiratory rate of 56, SATs of 97% of room air, cap refill of 2. He has bilateral chest tubes. He's sleepy but easily arousable.
So
This
without any solution, I just want to point out what Tim said. Dr. Chismara said something about how the assessment, and I think whenever something doesn't make sense, so when you first talked about this case, we have a 4-year-old and you were thinking about stridor and we were thinking about airways, but everything you're saying, there's no wheezing, there's no other rash. So this is where maybe I'm going into too much of we're getting drawn into that pediatric black hole, but you have to keep your mind open. And I think that is really difficult to do in situations where you have critical situations. So it looks like you've stabilized the bilateral pneumothoraces. And I think the first thing to do would be to get a much better assessment because this clearly doesn't fit with an asthma attack or near drowning or something, or maybe, I don't know whether somebody stepped on the kid next to the pool, but I mean, that would speak to me about a traumatic.
And
mechanism.
stung by a bee at the same time.
Okay, yeah. Or somebody gave you peanuts or something, but yeah, so assessment too.
All right, so now that you're okay with them transporting, what do you want to do? Are we doing something before they transport? We're gonna transform like this. What's your thoughts?
What do you have air leaks or what do we know about the chest?
You have air leaks bilaterally,
Oh,
large
so-
air leaks.
And so they're confirmed in place. We have an
yeah.
X-ray confirmed in place.
And then when they assess them, they find the sub-Q air all the way up. Even more of a mystery, huh? How we transport them? We're just leaving them like tripoding on the stretcher? What do you think? What do you want to do?
So I sit this kid up as high as possible, of course, strapped into the teammate.
Do you want to
And-
intubate them?
What if his airway goes south? Do you want me to try and instrument this kid's airway and RSI him? I mean, do I just take it as it comes?
I would want to try to resuscitate him a little bit more before we intubate him. And he's 4 years, not 4 months. So I mean, let's try to get a blood pressure on him. Figure out what our other hemodynamic indicators are. Does he need volume? Does he need,
Let's
you know,
say he's hemodynamically stable.
pretty tacky there.
Yeah, let's say he's hemodynamically stable. Like, I'm not worried about his blood pressure. He's perfusing well, got good cap refill.
Is the Strider result that we had initially?
No, still a little bit of Strider.
Have we tried anything else as far as,
He's gotten IM epi, he's gotten buterol.
so I guess, I mean, I'm concerned also that there's a second cause for the decompensation for the shock. I mean, I think again, if he got IM epi and he had some response with the IM epi, then I might be thinking towards, an epinephrine infusion.
No response.
Before we take off. No response from the IM epi?
Mm-mm.
He just gets more
No.
tachycardia.
Didn't help, it just brought his heart rate higher and higher, because the ER gave him a dose too. Before they did the
Ah,
X-ray and
gave him
found the
one
pneumos.
Gotcha.
So we intubating him? We're not intubating him for the route? What do you think?
So again, I'm still looking for, a good answer like Occam's razor. There has to be generally one thing that's going to cause all of the pathology. Obviously, that's not always true. A lot of times there are true unrelated things going on, and I understand that. At this point, personally, I would not be overly comfortable taking this patient and running out the door. I would want more information. If we're able to get this patient to a CT scan, to know the truth, really give us a much better idea about what's going
Not
on.
available. It's a little critical access hospital. There's no CT there. I hate when that happens. Man,
All right.
did I do my job and stump them?
You're doing a great job.
All right, this was my job, is to stump you.
So, and then the other things that I would be looking at is I would already be going down my typical airway pathway, just looking at this X-ray, I don't think that the patient has a lot of excess body tissue, there's not a lot of body cavities that we're gonna have to worry about. If we do have to end up going down the surgical crike pathway, then, I wanna have that in my back pocket in case I need it, but that's always gonna be my last ditch effort. But yeah, certainly I'm gonna be still looking for something that makes a little bit more sense that encompasses all of the pathology at the same time.
So sometimes it's really attractive because you also go back to what you know, right? So intubation is one of these things where you can control variables. And I remember very clearly, in my training at shock trauma, my first indication for intubation was to get somebody to shut up, right? So the scene is so difficult. And I think there's a simplicity, right? So the kid's not acting right, you want to take the airway. So I love to be very aggressive about airways, but what this suggests, if you have persistent air leaks on the chest tube, which is a real problem, and you are having subcutaneous emphysema, the challenge is if he's got a tracheal injury, we're just going to blow this patient up and not be able to fix anything. So I don't know, but I would say that in this situation, we are oxygenating, right? And I think intubation can be, if you don't know what's going on, it can be a little bit of a disaster. So although, again, I don't have the answer and we could be completely wrong, I think we have to be careful because intubation provides a solution, right? It'll stop the patient being excitable. They won't be tripoding. But my question in this case is if we don't know where the tracheal tear is, we're going to cause another problem by relaying our own fears. Because I think that rapid sequence intubation would be, easy. Like, I mean, you could do that. I would just worry about the downstream effects if this kid's got an unresolved tracheal or some other injury.
Then I totally agree with what you're saying. And what makes me nervous is that this patient has something that likely nobody can fix at this emergency department, at this hospital. And we need to go to a specialist center as soon as possible. Because they thinking about the anatomy, like all of this must come to some kind of big airway issue, tracheal issue. And there's nothing in this emergency department likely that's going to be able to fix that. And if they decompensate, I don't know what else we're going to be able to do without having a surgeon or an operating room or bronchoscopy or something like that available.
where do you guys land on the concept of some airway is better than no airway? And does that change in terms of transport time, type of patient? Are we willing to sort of like run with the patient, keep our fingers crossed? Or do we want to, Dr. Launder said, control the variables in as much of a controlled setting as we have before we go? Where do you guys sort of land on that? And what is it, I don't know, what does it depend on?
So I agree with that. You know, if I knew what the problem was I was fixing with an intubation, I feel pretty comfortable that anatomically, this shouldn't be terribly difficult, but I don't know what the problem is I'm fixing. And in fact, if that's going to fix the problem at all, I think there's an equal chance that it makes my problem worse. There's nothing here that tells me I need to wait for a second. Agreed. I don't think things look good, right? A respiratory rate of 56 is not reassuring. But I might be willing to try a cannula and try to manage some of this respiratory distress non-invasively. Being concerned that with persistent air leaks from bilateral pneumos, the constant pressure is likely to make this worse unless I can get that to pass that tear. You know, and I don't know that I can. So I'd be fine to try to non-invasively bedside for a couple of minutes and see how much benefit I get from that before I'm making a rapid move out the door.
Yeah, this is where it gets, I don't like being stumped on a panel that we're invited to, but this is where it gets difficult. And obviously doctors call for help all the time. This may be a situation in which you get a pediatric critical care specialist on the line to say, this doesn't make sense. This is what I'm thinking. And always in the back of my mind, whenever we do these things, I think you're seeing in the world of critical care transport that you no longer can operate on axioms, right? You can't just say GCS less than 8 intubate, or we never take people without a secure airway. These patients are so highly complicated, nuanced that you have to adopt your approach to the particular patient. I remember very clearly, if you're thinking a tracheal tear, we had a transcervical gunshot wound with a tracheal disruption and a chest tube with a massive air leak. And in that particular patient, that would have been disastrous. And it was a very difficult situation, but I think every situation is different. You apply your principles. So one other thing here is, you know, doctors ask for help as well. I think we have to basically be thinking about transport to go downstream. And if you're able to temporize that kid in the PD mate, you may want to try to calm him down with some high flow. I like that idea a lot with some ketamine and some high flow and see what happens. And then if you have to intubate the kid because you have total airway compromise, you can't ventilate, you'd be thinking about right main stem or trying to go past the tear. But I think that would be pretty disastrous in a kid, a 4-year-old with an air leak. But what would MedStar do?
Fortunately, we have pediatric critical
That's
care.
right.
They weren't available for this call. So I got.
They weren't available.
Yeah. Is this what's been on? I can't even tell.
There you go, Dr.
Yeah.
Sasser.
Didn't think so. Yeah, no, I agree with everything that you're saying. I mean, the fortunate thing is that the patient already has bilateral chest tubes,
Yeah.
so you don't have to worry about really overexpanding their lungs. So you've at least got that working for you. But, you know, I'm going to go back to, you know, what I was saying before. You know, I would want to assess the airway, try to figure this out, but I wouldn't want to take the airway unless I absolutely had to, because we don't actually know what the pathology is. So I have to agree with you on that one.
So you guys have the luxury of talking to a critical care attending, and they make the decision not to intubate the patient, to just transport him as is, because they don't want to cause more damage. He gets taken to the trauma bay. They bronch him because they suspect a tracheal injury. They find one. They keep him intubated they find a partial thickness one, keep him intubated for 5 days. They repeat the bronch and show the resolution of it. Upon further questioning of these unreliable parents, they find out their 100-pound, 10-year-old cousin pushed him into an entertainment center, and a small red mark appeared on his throat the next day. Good job. Yes. This is the zebra. This is the zebra, not the horse. All right.
Yeah, perfect.
All right.
Thank you, sir.
We're gonna finish on the winner, right? If we get easier as we go.
Sure. So
Oh, cardiomyopathy, really?
case number 3, here's your easy case. Here's your easy case. So case number 3, 22-year-old male, past medical history of congenital cardiomyopathy with an implanted VAD. VAD was implanted about 8 years prior. He's a standard 22-year-old in college that doesn't really want to have a VAD. He's a frequent flyer to this ED for drive line infections, for angriness at the drive line, right?
I know this guy.
Do you?
This is Monday.
Yeah. He presents overnight for altered mental status. His friends in college find him and they're like, he's acting weird. They've done this before. They've sent him to the ED. He was found hypotensive, tachycardic, hyperthermic, diaphoretic, and his VAD just keeps alarming. So they put a pillow over top of it because it just keeps yelling low flows. Currently intubated, AC volume rate of 24, 540, keeps 5 on 100%. His initial gas, 6.97, 56, 274, 11 with a lactate of 10. Told you, easy one. Discharge home, right? Dispo home. All right. So that's the initial presentation. We get there, we find him on 0.5 milligrams per kilo of levo. He's on Neo at 180. He's on fentanyl at 100. They've given him 8 liters of Cristoid because the thing kept saying low flow, so he must be dry. 3 amps of bicarb, Dr. Chismar's favorite medication. Gave him some antibiotics, and they gave him a unit of PRBCs because his hemoglobin came back at 6.9. And they're pretty sure the drive line is the source of infection because it's angry and red. Okay. What are your thoughts so far? Sick, not sick? What'd you say? Ben answered that. Not sick, right? Dispo home. All right. So current vitals, I walk in, heart rate's 140. Non-invasive blood pressure is 61/24, which gives me a map of 36. He's breathing 24 times a minute on the vent, because that's what we set the vent at. Why is my slides not going forward? There we go. And I get a point of care gas, I do an EPOC or an ISTAT, and I come up at 7.02, 50, 46 because it's a VBG, 13.2, and a lactate of 11.7. So my questions to you guys start with, how do you want me to approach this patient? What is step one? This is what I walk into. They are at the end of their rope. There was another team that tried to go get this patient, and they felt like they were too unstable,
You don't need to call Express Care out at this point.
and they left. It was not Express Care.
We'll transplant an organ in this patient. You don't care. No such thing.
What are my priorities at work as soon as I walk in the room, right? ER doc is like, done. I'll give you whatever you want. Just get him out of here. I'm out of options. Very supportive, and the nurse at the bedside is running around, wants to help, but is at the end of their rope as well. So what are my priorities at work on this patient?
So number one is going to be getting a lot more information. So
Okay.
I'm very hopeful that he was at a facility that knew to get an LDH and an INR on this patient, so we can figure out if the patient's actually been compliant with his anticoagulation. I would also want to know.
He has been compliant with anticoagulation. Okay. He's appropriately anticoagulated.
And we would also be looking at the LVAD numbers, seeing what other alarms might be alarming.
He's pulling about 2,500 RPM and about 2.4 liters a minute is what the screen tells me.
Okay, so we've got quite a few issues. I'm still going to be concerned about pump thrombosis in addition to sepsis, especially in a patient who has a cardiomyopathy and received 8 liters of normal saline, who now probably also has a hyperchloremic metabolic acidosis, as one of our previous lecturers very aptly went through earlier. I'm looking at a lot of issues to begin with. So we've got low flow on the LVAD. We've got a low MAP, which is not going to be sustainable. We've got a VBG and an ABG both showing both are acidosis, but also the patient is not blowing off all of their CO2. So I'm also concerned about insufficient respiratory compensation, and I'm thinking about how I'm going to manage this airway in addition. So those are at least my initial thoughts.
Okay. What's the first thing you want me to attack? Am I attacking the blood pressure? Am I attacking the ventilator?
So, I mean, I would say I would be looking at, the vent is going to be one of the things I'm looking at. Where is his issues at?
He was satting 99%.
99%. So I'm going to try to take as much pressure off of the heart as I can. He's only at a PEEP of 5. We could even still take that down. His tidal volume is 540. Let's see,
It's
where's his?
appropriate for him. He's a big
Appropriate.
guy.
Okay. So I would still want to try to improve his ventilation, understanding that he's not perfusing as well as he probably should be, but I would also try to optimize blood flow and work on his vasopressors at the same time.
How do you want me to do that? Am I changing my vasopressors? Am I adding epi? He's on levo, vaso, or not levo, nia. So am I giving push dose epi to give him a bump and get myself a cushion to be able to manipulate some things?
What does my LVAD coordinator recommend?
You can't get him on the phone.
What? This is not MedStar is all I'm going to say. I mean, I think that epi is certainly reasonable. You've already got the peripheral vasopressors going, so I think something that's more inotropic might be beneficial.
Sure. Okay. So start an epi drip. Okay. Starting at 0.05, 0.1, somewhere in there.
I mean, I usually start at mics per minute, so I would start at 5.
Okay. All right. Anybody else got any thoughts on what they want to tell me how I should attack this patient? So I give him the epi and it helps a little bit, but not a ton.
I mean, I would say a couple things. I mean, I would probably redo the math on that vent, but I mean, maybe he's a big dude. But I think perfusion, first of all, of everything else here, the lactic acidosis, which we knew, the fact that he's still hypotensive after 11 liters, we absolutely have a perfusion problem, and none of the numbers are going to improve unless we can deliver oxygen. So in addition to the 9th liter of saline, I would probably I would consider blood. And one of the other useful things I learned from shock trauma is there's no such thing as a maximal dose of levo. So we've really got to maximize our pressors. And that's important because we have to find out that if he's responsive to those vasopressors. So this dose of levo, we would call at university a whiff. So I would suggest that we can maximize that a lot, and you could add vaso. This is what we're talking about earlier, right? So it's all about how do you maximize what you already have. A patient in septic shock like this, you could even be thinking of maybe a stress dose of steroids. So this is not a comprehensive sort of strategy, but clearly I think we all can agree that he's under resuscitated from sepsis. And that is something we can do in terms of helping to fix perfusion.
Okay.
And we could call stat.
So you double the levo and it doesn't do anything. It doesn't really do a whole lot. One of the questions I have for you is, this is a VAD patient with a non-invasive. How valuable are those numbers to me? And is there an argument to say to the sending facility, is there an argument to delay for an A-line in this patient? And that brings around, I'll ask my follow-up question after that, but is there value to delay? The ED doc tells me she's not credentialed to put an A-line in. So they have to get the ICU to come down, which is going to take some time. But is there an argument to delay for an A-line in this patient?
What's your transport time?
40 minutes by air.
The A-line just called back and the patient's hypotensive.
Okay. Is that your final answer?
One of the arguments I would make here is that this patient, the care you can deliver to this patient can be done on scene.
Sure.
And you're not, when you get to the receiving facility, they're not going to necessarily do anything different. So having that A-line while you continue to do your resuscitation is going to give you more information so you can direct your resuscitation better. So I would argue, yes, if the A-line is possible.
And not only that, I don't know that A-line is really going to delay your transport. This patient is not somebody that we're going to scoop in.
Yeah, sure.
Right?
Fair enough.
We've got an hour of bedside time before we're ready to go anyway. So I don't know that we're delaying necessarily. So I would ask them to start doing, I'm not gonna, if everything else looks good and they're like, hey, I just made my 19th hit for an A-line and I really suck at it, we're not going to try it 20th time. But I think it's reasonable to ask for it. I'm also looking at this and I'm worried about afterload, right? We've got a bunch of Neo on board. We just gave this guy 8 liters of fluid. Like, we didn't make life anything here with his cardiomyopathy heart. And,
Just helping that heart along.
yeah, interestingly, his LVAD flows are not as bad as I was expecting. They're not amazing, but it's working. They're sustaining. So I don't know that I've got to, I want to make things easier. I'm with you. I'm going up on the norepi or adding epi and trying to get off of that neo pretty.
Are we adding vaso too? Does everybody on the panel pretty much agree vaso's appropriate?
Get the neo off, replace
Yes.
the vaso.
Then my follow-up question is, we've decided to put an A-line in this guy. Nobody on site can do it. Is this an argument for the flight crew, the transport team to be able to place A-lines? Is there utility in doing that? Nobody's gonna jump on that grenade, are they?
Yes,
Okay.
with some hesitation. It depends on, I think it's dependent on each agency.
Okay.
And what type of missions you fly, where you're flying them to, and the capabilities of your typical receiving and referring.
That was really well said, and stay tuned for, I battle this with Jason back, the National PHI Medical Director, who's like, he sees an A-line and he wants to stamp it out with violence. But, we are an interfacility critical care transport program. And when you have, if you have morbid obesity, no pressures, and you're cycling the non-invasive for the 80th time, and then you're dumping in pressors peripherally, I think you can make an argument that what is it going to do? And if the answer is it's going to inform your therapeutic decision-making, I think you absolutely have an indication. But as my colleague here just said, you have to make sure that, there's always a risk because it's training and time. And in order to make people, I think, proficient in this, you're going to have to take time away from something. So I like the idea of A-lines. We haven't figured out, just speaking from our program, how to kind of work it in. But I think it's, especially when you're talking about the resuscitation of septic shock patients with no blood pressure, I think that idea is very attractive. I would support it.
I think the benefit here is that, I'm thinking about ultrasound for this patient. And if you're going to teach your crews how to use ultrasound, A-line is like a really easy stuff from there.
That was mine. Thank you for that. Thank you for that transition in there, Dr. Carpenter.
Yeah.
So is point of care ultrasound, is that going to inform your care on this patient? Yes, I'm going to use it to put my A-line in, but am I getting cardiac windows? Am I getting a 4-chamber? And does that change my pressor strategy? Or at this point, it's just rocket fuel, dump it all at them? Do I take the time to, maybe I'm not super proficient, right? Because I don't spend a lot of time doing cardiac ultrasound. It's going to take me a little while to get my windows. Is there an argument there for that? Does that change anything? Good, I'm going to use my ultrasound to put my A-line in, but do I spend the time to get the cardiac windows?
I'll take the hit. So I think that cardiac windows or the ultrasound in general will add nuance to the care, but I don't know that they are going to dictate the care. And I think you can probably do it without it. Do I want that information over the next 24 hours in the ICU? For sure. Is it really going to have a dramatic impact on the upfront resuscitation of this patient, who I think is probably volume long, not squeezing well, and I don't need an ultrasound to tell me that? I'm not so sure that, it adds nuance, but it's not going to fix the problem or dramatically alter what I'm doing.
It's not going to give you really super valuable information.
Okay. I think the value of ultrasound here is not in the cardiac windows, but in ruling everything else out. No pneumothorax, no pericardial effusion, et cetera, because this sounds like sepsis, but maybe it's something else.
Make sure he doesn't have a driveline infection and somebody kicked him in the abdomen and he's got an RP.
Exactly.
Sure.
We'll make sure he's not bleeding somewhere too. His initial hemoglobin was 6.9
Sure.
as well. So devil's advocate, he is taking his anticoagulation.
Yeah. So
Although you raise an interesting issue, I don't know if I'd do the pericardiocentesis on the LVAD patient, but why not? But you raise an excellent point. You gotta know where your tools fit in. And I think having a crew look at the ultrasound, we all know, obviously, for vascular access, I think there would be a lot of challenges, not to mention the fact of getting good quality images for this particular patient. But if you're asking specific questions, such as, did this patient meet the other pediatric patient in the pool and was he kicked in the gut? Yes. Or he was minding his own business when the two dudes from Baltimore,
Yeah, those dangerous things. we do.
That's right.
Yep, walking his grandmother to church.
Man, the epidemiology on the fence.
So leads me to my next question. Okay, we've started the epi, we got the vaso going. It doesn't seem to be making a huge difference. We got the A line in, and guess what? It tells me that he's hypothermic, right? Thanks for the A line for calling and giving me that heads up.
Like, well, Dr. Counselor told me to assess and be equanimous. I was calm in the face of adversity.
So we've now dumped 1.5 gallons. We guys on rocket fuel, and it hasn't made a huge difference. What's my next step? We guys talked about the ventilator potentially. He's being underventilated. Is there a role? And I'm going to stand on this side of the table because I heard this is going to trigger you, Dr. Chismar. Bicarb and calcium in this patient. Do we give this patient a couple amps of bicarb, appropriately manipulate their ventilator if need be? Is there a role for calcium? You guys already talked about how calcium is the magic drug in the hypovolemic shock, the hemorrhagic shock patient. Is there a role here, as I heard somebody refer to it as God's inotrope? I've heard calcium chloride referred to as God's inotrope. So is there a role?
I mean, I think, in general, if you think that this is sepsis, I mean, most of the time you're really giving sodium bicarb, you're converting it to hydrogen ion, you're making their acidosis worse, at least regarding bicarb.
Okay.
So I mean, you certainly could try more bicarb. Looks like we're already 3 amps in. I don't think at this point it hurts. As far as the calcium, again, I would say again, if we've tried all these other vasopressors and we're still not getting any effect, certainly. But I don't think, I mean, I'd actually want to, if we're going to be there for an hour or so, repeat this guy's H&H as well to know where we stand with that.
I ran an epoch and I get all those labs and it's about where it was. It's up to 7 and 7.5.
Gotcha.
So he doesn't seem to be bleeding.
Yeah, so increases respiratory rate by 25%.
Okay. Sure.
You're underventilated, you're not under bicarb.
Sure.
His primary problem is not carbonate deficiency.
Is the bicarb
many problems? It is not a bicarbonate.
it's not a bicarbonate deficiency. Is the bicarb going to buy me some time from a vasopressor standpoint? Is it going to make my vasopressors work better potentially?
No data.
Okay.
I give calcium. I agree. There's no harm in calcium here.
There's a lot of discussion of bicarb drips. Is that a different situation than push, or is it in the same realm? Or I've seen a lot of bicarb drips.
As calcium is that bicarb is the devil's drug.
Fair enough.
See, it's not just me.
I didn't think it was just you.
The RCCRU would have already had him on 10 bicarb drips, but I think the other issue is, so we don't have any good data on this, right? But I think the triggers, so everything has different considerations. So when you're against the end of your rope, we already talked about optimization of vasopressors, calcium. So he does have a pretty high lactic acidosis as measured by carb is 11. I mean, you could start him on that. I just think that would be, as we said, we don't really have a strong indication. We have other things that are going on. So the thought is that for hemodynamically unstable patients with an uncompensated acidosis, it may be temporizing, but I don't think he's going to, certainly turn around. So I would not probably start that bicarb drip at the expense of other potentially therapeutic interventions.
If his end title comes back, I'm looking at his end title and it's 35. Is that a reliable number for me to trend as I try and blow his CO2 off? No. I see Dr. Moore shaking his head.
I think if you have a good gradient between the ABG and the
if I've
CO2,
got a gas and I got an end title and I can say the gradient is this, then valuable as a trending tool. But so I can believe that, right? In transport, you can say, okay, you're not going to draw serial gases, but we're going to take his end title from 35 to 25. That'll be the goal.
So it can give you an idea about where the patient currently is, but you're still missing the pH as the actual indicator.
Okay.
And what's happening after that delta, I don't know, right? So you've got a gradient of 15, you've got a PCO2 of 15 and an end title of 35.
Sure.
And if I reduce his end title by 10, I actually don't know what happen that in CO2? Did it go down by 10? Did it go down by 6? Or did, I do some great medicine and now he doesn't have a DC mismatch anymore?
Okay. Yeah, no way to know.
It's better.
Sure.
I would say it's better. What that better is.
Okay. All right.
I mean,
Thank you, gentlemen. We're gonna open it up to